Добрий вечір, дорогі учасники та учасниці
Greetings,
вебінару.
dear participants of the webinar. Thank you so much for joining us here today, and thank you so much for an active registration to our event. So we are waiting for over 1,000 participants today. This webinar is a part of the training project on the professional development in mental health. This project is being implemented by the Coordination Board on the Mental Health of Cabinet Ministers of Ukraine, within the All Ukrainian Program of Mental Health. How are you? By the initiative of the First Lady of Ukraine, Olena Zelenska. We are speaking on the Zoom platform, on the Facebook page of the Coordination Center, and also on the YouTube channel. How are you? Today's webinar will be dedicated to the interventions and address the mental health challenges in children with autism and in general in autism. Our speaker, Peter Satmaris, the co-director of the Kendall Center for Child and Youth Depression at Center for Addiction and Mental Health Toronto, Canada, and also senior scientific employee of Campbell, and overall is one of the leading world experts in terms of pediatric and teenager psychiatry. Dr. Satmaris, greetings to you. Thank you so much for joining us in Ukraine and being in Ukraine with Ukrainian doctors. I'd like to add that our speaker is well known in his research on autism, and today we're going to have a few comorbidities in autism as well covered up, how to timely diagnose them and detect them, and how to effectively treat based upon the modern clinical approaches and the results of the international research. So, I would like to remind you that traditionally the webinar will be going for an hour. This switches for the lecture, and then in the end, half an hour for Q&A session in case we'll have questions. Dear participants, we encourage you to leave your questions in the chat. Leave your questions under the comments on YouTube and the Facebook. We will voice them out with the speaker in the end of his talk. Dear Satmari, passing the floor to you, and I wish you all to have a fruitful lecture. Thank you so much, and the floor is yours.
Thank you very much for the invitation to talk. I'm honored that you have invited me. We're all in Canada very strong supporters of Ukraine, as you may well know. Canada has the largest Ukrainian diaspora in the world, and we think of you often and hope that you're safe and that your families are safe. Slava Ukraine. So now I'll start the presentation, which is really to talk about mental health comorbidities in autism. Okay, my slide is not moving. I seem to be frozen.
Can you try stop sharing and sharing again?
Okay. Yeah, that may be the problem. So let me share again. There we go. You see the next slide? Excellent. So my objectives today are really to make you aware of the prevalence of common comorbid mental health challenges in autism, to understand how to assess impairment and how to avoid double counting in autism, to appreciate heterogeneity in the course of key comorbid mental health challenges in autism and some of the implications of that for clinical practice, and to be aware of recent rigorous evidence syntheses for both pharmacologic and psychosocial interventions to address common mental health challenges in autism. So just a word about autism to set the stage. Autism, as I'm sure you're aware, is a complex neurodevelopmental disorder that affects the way a person communicates and relates to people and the world around them. Autistic tendencies can be recognized in many individuals as part of human variation. Sometimes it can be as severe, and sometimes it can be impairing. The latest Canadian data on the prevalence of autism is 1 in 66, and it's worth pointing out that most of the people with autism in the world are adults. The impact of autism is far greater when you consider the broad-ranging needs of families, including siblings, living with autism and the economic cost to society. I like this figure of autism spectrum disorder. Hereafter, I'm just going to use the term autism. It's a heterogeneous spectrum disorder involving deficits in multiple domains with significant comorbidities. So I like to think of sort of three core essential elements: social communication deficits, restricted repetitive behaviors, and cognitive deficits, and common comorbidities such as language difficulties, common mental health conditions in between 30 and 50% of individuals. And we mustn't forget medical comorbidities as well that occur in between 25 and 40%. You can have a range of severity of autism that goes from strict, or maybe the new term is profound autism with high support needs, to much milder manifestations, some of which are not associated with impairments at all. The sex ratio is 4 males to every female. The disorder is changing in its epidemiology. It's the individuals with intellectual disability are much less frequent now than they were in prevalent studies 20, 40, 50 years ago. There's a lot of discussion in the world, especially over the last week, about the changes in prevalence in autism. And I think we all agree, experts agree, that those changes are due to changes in the diagnostic criteria, to better case finding, and diagnostic substitution. In other words, the prevalence of intellectual disability and mental retardation is going down at the same rate as the prevalence of autism is going up. So I think what we're doing to a certain extent is substituting autism for intellectual disability. And it's best to really think of autism as a disorder of multiple mental and physical health conditions and cognitive deficits. Alongside this medical model, there's a new framework that has emerged for understanding autism recently, and it's referred to as the neurodiversity framework. And it sees autism as a social disability, not so much as a medical disorder. So the neurodiversity movement has challenged this medical orientation with its emphasis on innate biological deficits and differences. So instead, autism is a variation of normal, or of being typical. Autistic traits are normally distributed in the population, and the threshold for being autistic is socially determined, not medically determined. The deficits and disabilities associated with autism are the result of the environment being unable to accommodate the person with autism. In an accommodating environment, there is no disability associated with autism. And I think it's important not to think of these two views as in competition with each other, but to think that they complement each other. So having a both medical and a social disability framework is, I think, very useful. The common mental health conditions that we're going to cover this morning are anxiety disorders, depression, self-harm, and ADHD, attention deficit hyperactivity disorder. To talk about these mental health comorbidities, excuse me, I'm going to refer to a study that I've led over the last 20 years called the Pathways in ASD study. This is a longitudinal prospective study of 421 autistic children diagnosed when they were between 2 and 4 years of age, and we've now followed them up into adolescence. We have 5 different sites across Canada. We collect information in a variety of different ways, and we're particularly interested in following the trajectory of autistic features, cognition, daily functioning, and mental health. This slide, I think, illustrates a very important finding, not only in our studies, but I think an emerging trend in the literature is the importance of heterogeneity in trajectory. On the left-hand side of the slide, you'll see that there are basically 2 subgroups of kids with autism who change with respect to their autistic symptoms over time. There's one group that has high autistic symptoms over time, and there's another group where the autistic symptoms are going down. They're being reduced over time. If we look at functioning on the right-hand side of the slide, we use the Vineland Adaptive Behavior Scale, and instead of 2 trajectories, we find 3 trajectories. So there's one group that has high functioning with an increase in the early years and then a bit of a flattening off. Then there's a middle group, which is kind of flat at the beginning and then starts to increase. And then there's a third group where their functioning decreases over time. So again, heterogeneity in the trajectory of functioning. And I'll just say that the kids in the different autistic symptoms trajectory on the left are not the same. They don't travel with the trajectories on the right. Those are different kinds of kids. I want to spend just a moment to illustrate the importance of transition points in the trajectory of autistic symptoms. So on the left-hand side of this slide, you'll see that again, we've got 2 trajectories of autistic symptoms, one going down and another which is more flat. But you'll also see that when the kids enter school, there's a turning point for that red group at the top. There's a slight reduction in their autistic symptoms. And then when they enter school, their autistic symptoms flatten out. Whereas the kids in the green line, their autistic symptoms continue to improve whether or not they're in school, whether, even after they have entered school. So kids with autism experience these transition points that have a significant impact on their developmental trajectories. To summarize the basic findings of our study is that autistic children follow different pathways regardless of the domain that we're looking at, usually between 3 and 4 trajectories per domain. Autistic people show a lot of variation in their symptoms and their functioning, in their mental health at one point in time and with the same person over time. The implication of that is that individual prediction is impossible. We can predict prediction for groups of kids, but individual prediction is virtually impossible. And as a result, a one-size-fits-all approach to supports and services simply will not work. This slide illustrates a meta-analysis that we did a number of years ago, looking at the prevalence of mental health conditions in autism. So the most common mental health condition in the meta-analysis is ADHD, which occurs in about 28% of autistic kids. Anxiety disorders, the second most common, occurring at about 20%. Depression is very important, occurring in about 11% of kids with autism. Bipolar disorders, schizophrenia, obsessive compulsive disorders, much less common in kids. So I'm going to start with talking about anxiety disorders. Anxiety disorders occur in about 20% of children with autism. Anxiety disorders are very difficult to recognize and diagnose. The symptoms overlap and get confused with the repetitive stereotyped behaviors that we see in autism, such as insistence on sameness. So these are kids who become distressed when there's a change in their routine or a change in the furniture in their room or some change in their environment. An important question to ask is whether the developmental trajectories of anxiety and other mental health challenges have similar trajectories to that what we saw with the autistic behaviors. And what is really the relationship between this autistic domain of insistence on sameness and symptoms of anxiety? So this slide illustrates us taking measures of insistence on sameness, IS, and symptoms of anxiety at 4 different points in time and looking at the interrelationship between these two domains over time. And the bottom line is that insistence in sameness at one time point predicts anxiety at another time point. So insistence on sameness is a risk factor for later anxiety disorders. It may be that insistence on sameness is changing into anxiety disorders. The reverse is not really true. Anxiety disorders do not predict later variation in insistence on sameness. This slide illustrates the different trajectories over time of insistence on sameness on the left and trajectories of anxiety on the right. There's 3 trajectories of insistence on sameness. One group that has a lot of symptoms of insistence on sameness, a rapid increase in early childhood, a bit of a decrease, and 2 lower ones. You can see the trajectories of anxiety are much more complex. There's one group of autistic kids, around 13%, that have high anxiety all the way across. There's another group, however, that's low at the beginning, and then as they transition into adolescence, their anxiety symptoms go up. There's another group that has a lot of anxiety early on, but it goes down over time. And then there's a relatively flat group at the bottom with a bit of an increase when they go into adolescence. Again, there's some overlap between the kids in the different insistence on sameness trajectories and the different anxiety trajectories, but not a perfect one-to-one matching. There's some things I want to share about assessing co-occurring anxiety disorders in autism. The anxiety disorders that you see in autism will fit the traditional anxiety disorder categories: separation anxiety, selective mutism, specific phobia, agoraphobia, panic attacks, most commonly social anxiety, and generalized anxiety. But the presentation can be a little unconventional because autistic people will have variation or difficulties in emotion processing and their cognitive style that can complicate how they experience anxiety and how they show it. And also, some of their communication and intellectual differences can modify how anxiety related feelings are expressed. So, some tips on the assessment of anxiety disorders in autism. Stick to the DSM or ICD anxiety disorder categories. They're appropriate, they're applicable, except maybe for early onset specific phobia, which is so common in autism. You know, being afraid of spiders, being afraid of thunderstorms. I don't count that as a co-occurring anxiety disorder. Very important to not double count symptoms. By that I mean a child can show a lot of distress and worry about a change in their routine. That's That's appropriate. So that becomes a symptom of insistence on sameness. Don't also count that as a symptom of anxiety, of generalized unrealistic worry. You can't count the same behavior for both an anxiety disorder and as a symptom of autism. Very important to follow the developmental trajectory of a symptom. And generally speaking, the anxiety disorder symptoms have a later age of onset for the majority of kids. Take advantage of multiple informants. Collecting information from teachers can be very, very useful. I think emphasizing the behavioral manifestations of anxiety more than their cognitions or emotions is important because of their difficulties in communication. And the issue of impairment is very difficult and complex. To have an anxiety disorder, there must be impairment due to those anxiety disorder symptoms. But autism itself has a significant degree of impairment. So you have to determine whether the impairment associated with the anxiety symptoms is over and above the impairment that's due to their autism. And this can be a difficult clinical judgment to make. There are some measurement tools that are quite useful in the assessment of anxiety disorders. The traditional measures of anxiety, questionnaires, for example, have uncertain psychometric properties. The RCADS, the Revised Children's Anxiety and Depression Scale, has been modified to develop an anxiety scale for children with autism spectrum disorder. I've put the reference up here. You're, of course, free to use the slides after, and I'll share the slides with everybody who's attending this seminar. And there's also an interview schedule, the anxiety disorders interview schedule. There is an autism addendum to that interview published by Connor Currens, and I've listed the reference there. There are evidence-based treatments for co-occurring anxiety in autism. This is a very nice systematic review. Most of them looked at the extent of the efficacy, effectiveness of cognitive behavior therapy. Most of the papers, they looked at 57 papers in total. Most described caregiver involvement in therapy, and they had to adapt the intervention in terms of its communication and intervention content. Generally speaking, both parents and clinicians reported positive outcomes in modified CBT for anxiety in kids with autism. Self-report didn't show that it was effective, but parents and clinicians do report that it's effective. So I think that certainly is evidence of its usefulness. I often refer to the NICE guidelines from the United Kingdom, the National Institute of Clinical Evidence, and they have guidelines on treatment of mental health conditions in autism, and they emphasize when it comes to anxiety disorders about the importance of adapting the method of delivery of CBT to autistic children. Some of the suggestions they have are doing some emotion recognition training, greater use of written and visual information, and structured worksheets. So making it more and more concrete as opposed to abstract, more cognitively concrete and structured approach than one might do in traditional CBT, simplified cognitive activities like multiple choice worksheets, involving a parent or caregiver to support the implementation of the intervention. So involving parents in therapy sessions, maintaining attention by offering regular breaks, and incorporating, I think this is very important and very useful, incorporating the child or young person's special interests into the therapy if possible. That will definitely increase their motivation. There is a literature on psychopharmacology of anxiety in autism, and there's this excellent systematic review by Deb et al. They report on 15 randomized controlled trials, 13 on antidepressants like SSRIs, 2 on anti-anxiety medications, almost 1,000 people with autism. I think the bottom line is there's no evidence for the effectiveness of either antidepressant, SSRIs, or anti-anxiety medications to treat either the core symptoms of autism or associated anxiety symptoms. And I think too many kids are on anti-anxiety medications, antidepressants for their co-occurring anxiety conditions instead of using CBT, which has better evidence of efficacy. I showed you earlier the heterogeneity in the change over time in in anxiety symptoms in kids with autism, those 4 different trajectories going up, coming down, and 2 that are stable. What that implies for clinical practice is that monitoring of outcomes is essential in view of the remarkable heterogeneity in symptoms and co-occurring mental health conditions. Measurement-based care is the application of reliable and sensitive clinical outcome measures to assess response to treatment. ICHOM, which is the International Consortium of Health Outcome Measurement, has developed core outcome sets for anxiety and depression and for autism. You may not be familiar with the term core outcome set. It refers to a minimal battery of outcome domains and measurement tools that should be employed in measurement-based care. They're developed in a rigorous, systematic manner with patient and caregiver involvement and very careful attention to psychometric properties. This is the core outcome set for autism. These are the measurement tools that they recommend. For measuring autistic symptoms, they recommend the repetitive behavior scale, the social responsiveness scale. To measure functioning, they recommend the Vineland adaptive scales, preferences for activities of children, child and family quality of life, and the McMaster family assessment. This is for family functioning. There's and also for co-occurring mental health conditions, they recommend the positive and negative affect scale, child behavior checklist, and for sleep, which is so common, they recommend the brief infant sleep questionnaire. You can go to the ICHOM website and look at this core outcome set in for autism in more detail. Let me turn now to depression. Depression is especially common in transition-aged youth with autism and in women with autism. And this is an emerging area, autism in females and women, that we're becoming more and more aware of, and the extent to which they haven't been properly assessed and diagnosed. Depression often occurs in the context of a previous diagnosis of an anxiety disorder. So autistic kids with anxiety disorders are at very high risk for subsequent depression. That's a red flag. Depression also occurs commonly in autistic kids, just like it does in neurotypical kids in the context of bullying, ACEs or adverse childhood events, loneliness, and social rejection. Some people with autism are acutely sensitive to social rejection and will become severely depressed. The presentation of depression in autism is the same, basically, as it's listed in DSM or ICD. It's true that some symptoms of depression are more common in autism than in neurotypicals. So depressed autistic people often will show increased irritability, They will engage in their stereotypies more frequently, like hand flapping, they'll do it more often. Going up and down stairs, they'll do that more often. There's less engagement in their restricted interests. There's a decline in adaptive functioning, sometimes a regression in skills. Again, really important to avoid double counting. In other words, flat restricted affect is a symptom of depression, but it's also a symptom of autism, as is a monotone voice, as is no facial expression. You can't count these as symptoms of both autism and depression. So that's why, you know, documenting the age of onset of some of these symptoms is essential to determine whether they've always been there, in which case they're a symptom of the autism, or whether it represents a change for the person. So they didn't have flat affect before, but now they do. That's more likely to be a symptom of depression. And I think new onset of sleep problems is a really important hint that there's a new co-occurring diagnosis of depression. What about the treatment of depression? Well, here we're not really, don't really have evidence-based recommendations to make. There are 3 systematic reviews. The first one, Schweitzer, says that cognitive behavior therapy and mindfulness-based therapy are effective for anxiety, but the results for depression are inconsistent. No conclusion possible. Witchers says social skills training is effective for children with depression, but otherwise CBT had a small effect size that was largely non-significant. Linden, I think, makes the conclusion that to me makes the most sense. And they say, until we have more evidence, treatment of mental health conditions like depression in autistic people should follow the evidence available for non-autistic people. That usually means psychoeducation, a psychosocial intervention first, and then a medication like an SSRI. What about self-harm? This is an emerging area, and I think it's becoming more and more important and something that I've become much more sensitive to in the last little while. We need a lot more research on self-harm in autistic people. The problem is there are no autism-specific measurement tools. But self-harm is becoming more and more common in autistic children. So prevalence studies show that autistic individuals have over a 3-fold greater odds than non-autistic individuals of experiencing suicidal ideation, suicidal attempt, or death by suicide. The pooled prevalence of suicidal behavior is almost 25%, 24.3% in those without intellectual disabilities. There's one meta-analysis which shows that the prevalence rates are 25% for suicidal ideation, 8% for self-harm or suicidal attempts, and 0.2% for death by suicide. So it's way more common than I ever thought. When you do systematic studies, it's definitely something that we should be paying attention to. Unfortunately, there are no psychosocial or medication clinical trials for the treatment of self-harm in autism. There is a protocol. There's one group who's doing a protocol, published a protocol looking at the possibility that DBT or dialectical behavior therapy, which is commonly employed for self-harm in neurotypical people, could that be effective for self-harm in adults with autism? To me, the recommendation like we had before for depression, still stands. In the absence of evidence, high quality evidence of what we should be doing about self-harm and autism, we should follow the rules really for the treatment of self-harm in neurotypical people, which really means two things: safety planning, treat the mental disorder if it's present, and address the psychosocial stressors that might be there. The rejection, for example, the romantic relationship that might have broken up, the disappointment, cyberbullying, all these kinds of things. In my experience, addressing these psychosocial stressors and taking a problem solving framework can be helpful in getting over that crisis of self harm. I've left the most common co occurring condition, ADHD, to last. It's the most common comorbidity in autism. There's a very nice systematic review by Annetta Krakowski looking at ADHD symptoms in autistic and in the general population. And the bottom line of this meta-analysis is that there's a lot of overlap between autism and ADHD, especially with respect to attention symptoms. So you can't really distinguish autistic people from ADHD people on the basis of the severity of their attention symptoms. The difference lies on social communication deficits, repetitive behaviors, and hyperactivity. So autistic people will have more social communication deficits, more repetitive behaviors. ADHD people will have more hyperactivity, impulsivity. Attention problems are the same. This slide is also taken from our pathway study. Annie Richards was the first author here. And this shows what the developmental trajectories of ADHD symptoms are over time. And for ADHD symptoms, we found the best fit was 5 different trajectories. There's one trajectory which is high and is stable over time. Excuse me. Another which is high at the beginning and early childhood, but then decreases by the time, a rapid decrease by the time of late adolescence. There's a moderately increasing trajectory. There's a low, a moderately decreasing trajectory, and then a pretty low stable trajectory, the red stable at the bottom. So again, a high stable group who have a lot of ADHD symptoms over time, a low stable group, and then all kinds of kids, their ADHD symptoms are getting worse, some are getting better. It's a whole mishmash. The point is that you have to follow those ADHD symptoms over time, emphasizing again the importance of monitoring ADHD symptoms over time in autistic kids, because you can't predict at baseline where they're going to end up. Unless they're very high, then they'll probably likely stay there, or they're very low, they're probably likely to stay there as well. So monitoring is essential. This is a meta-analysis that we did of medication use in ADHD symptoms in autism. And this shows studies that have looked at methylphenidate versus placebo, atomoxetine versus placebo, guanfacine, and then second generation antipsychotics such as aripiprazole, risperidone, and comparing aripiprazole versus risperidone. Really, the bottom line is that the medication with the best evidence for treating ADHD symptoms in autism is methylphenidate. You can see the studies in that particular group all favor the intervention. Atomoxetine, the evidence is not as strong, and so therefore that would be a second line choice. Guanfacine looks promising, but there's only one randomized control trial in autism for ADHD symptoms. So I wouldn't put, I'd have because the sample size is relatively small, I would not have guanfacine as my first line of treatment. I think the same goes for second generation antipsychotics. There's no reason to go to the second generation antipsychotics where the evidence is mixed. Um, if we can have methylphenidate stimulants, which we know is much safer. So always start, I think, with methylphenidate. If that doesn't work, then you can try atomoxetine or guanfacine. If that doesn't work, then a second generation antipsychotic like aripiprazole could be beneficial under the circumstances. So again, what we're doing in neurotypical children for the treatment of ADHD works in kids with autism that have comorbid ADHD. This is my final slide, and I really just want to give you a framework for supporting autistic children with mental health comorbidities. With some caveats, we can apply the DSM ICD criteria, identify sources of stress and adversity, identify areas of strength, then assess the fit of the child with the context. That is, how are they fitting into school? How are they fitting into the family? Make accommodations. What can we do to prevent the development of these co-occurring mental health conditions? Are there problems that we can solve? That's always the first thing to do, is to try and improve the fit of the child within their family, within their school. If the fit improves, stress will go down, the mental health comorbidities will go down as well. I've stressed heterogeneity as a essential core feature of the natural history and outcome of autism. What that means is that a one size fits all approach is not going to work for kids with autism for their mental health comorbidities. And we need to employ a measurement-based care framework in outcome monitoring and use measurement tools that are sensitive to change and can support us in making clinical decisions. Largely speaking, evidence-based practices that work for neurotypical children and adolescents generally will work for those with autism, with some adaptations as illustrated by CBT for anxiety disorders. Psychosocial interventions have greater evidence of effectiveness than medications. I think we have too much reliance on medications, not enough capacity building for psychosocial interventions, which I think is a very important step in the future. In Canada, autistic children with mental health difficulties are often denied access to generic mental health services because they have autism. I don't know if that's the same for you in Ukraine. Um, in my view, given how common mental health challenges are and the fact that generic interventions, psychosocial interventions, generally speaking, work. It's unethical for autistic children and adolescents to be denied access to generic mental health services because of their diagnosis, because they might have autism. So that's the end of my presentation. I'll stop sharing and we can go to the question period.
Дякуємо, докторе Сатмарі.
Thank you so
В
much,
нас
dear Dr.
насправді
Satmari.
дуже
We
багато
have
запитань.
so many
Дуже
questions.
чудово,
We
що
didn't
в
expect
нас
this many.
є
And it's great that you finished
доволі багато
earlier.
часу
You
на них.
finished 15 minutes early, actually, so that's great.
Пропонуємо
So I
розпочати
would
з
propose
такого
for us to
запитання
start with
від
the
нашої
following question
слухачки
from
Любові.
one of our listener
Якщо
named
у
after
дитини
Lubov
1
or
рік
Love in
немає
English.
вказівного
If a
жесту,
child
чи можете
1 years of
говорити
age
про
does not
аутизм у
have a pointing
майбутньому?
gesture, can this indicate autism? If the child at 1 years of age does not have a pointing gesture? Thank you.
So this question has to focuses on the emergence of autism in early childhood. We know from studies that autism tends to emerge between 12 and 24 months of age. 18 months is sort of the 50%. 50% of kids with autism will demonstrate signs by the time they're 18 months of age. Not pointing is one of the signs of autism, particularly if you're looking for pointing in the context of communicating or sharing interest. But I want to emphasize there's no single sign of autism that's pathognomonic. You need multiple signs of autism. So not pointing would be one. Not using gestures would be another important one. Not sharing would be another one. You have to accumulate these in the early stages and make sure that not pointing is not due to other things like being deaf, like intellectual disability, like some impairment in movement, restriction in movement, etc., etc. You get my point. Can you see me, by the way? Can you see my face? I'm not, because I
Так,
see.
ми бачимо вас.
Yeah, okay. Because I still see the screen there. That's okay. Good. All right.
Так, ми бачимо вас, бачимо.
Yes, we can see you well. Thank you
Докторе
so much.
Сатмарі,
Okay,
наступне
Dr. Satmari,
запитання це
this following
таке
question
до
is
рефлексії,
a sort of
воно
to more
про
to
останні
reflection because this is
дискусії,
about
чи
the
має
latest
зв'язок
discussion.
парацетамол
Is
до
there a connection
аутизму?
paracetamol to
Що ви про це
autism?
думаєте? Чи
What do you
може
think
це
about Trump mentioning about
провокувати
paracetamol and
розвиток
autism?
аутизму
Can
в
this
дитини,
promote
якщо
autism
вагітна
development in a
жінка
child if a pregnant
приймала
woman
його?
uses paracetamol in big quantities during pregnancy?
Okay, a little hard to hear. I think the question was, do I think that paracetamol, Tylenol, is a cause for autism, right? Is that the question?
In
Так,
mothers,
так.
if mothers use it during pregnancy.
Yeah. Okay. So how do I say bullshit in Ukraine? in other words, there is no evidence that paracetamol during pregnancy, a mother taking paracetamol in pregnancy, is a cause for autism. I mean, it is outrageous. It is an outrageous claim, and just another example. I mean, don't get me going on this. Okay, so how does this come about? This comes about from a meta-analysis which combined a number of different studies and when they combine the analysis and when they sort of use a lot of subjective judgment to weight the different studies, they conclude that possibly there's an association between paracetamol and amphetamine in pregnancy and autism. So there's a lot of judgment they involved in that paper, and this paper is the one that uh, RFK and the Americans used to justify their claim. There's a lot of judgment involved in that. The amount of increase is infinitesimal. In other words, even if they're right, the increase in risk to paracetamol is infinitesimally small. It's hardly anything at all. And then the most important is that correlation, which is what this is not causation. As you all know this, and the example I love is this one, is that eating ice cream in the summertime leads to increased drowning. Well, that's a correlation. That's an association. But of course, the reason for that association is when you're eating ice cream, it's summertime and people go swimming more often in the summertime, and therefore there's going to be more drowning. So this is the issue of confounding, right? Unmeasured confounders. And this is, you cannot draw an inference of causation from a correlation, and it is unethical and harmful to have done so. So that's was that unambiguous enough?
Докторе Сатмарі, ми не могли дозволити
I mean, we
собі,
couldn't allow
маючи
ourselves not
такого
to ask,
конструктивного
having this wonderful
спілкування з вами,
opportunity
не
of talking
озвучити
to you,
цього
not to voice
запитання.
this question,
Тому
because
дуже
if
вам
if it
дякуємо.
arises, it needs to be
Рухаємося
addressed.
далі.
But
Наступне
thank you so much for
запитання
your
про
unequivocal
те,
answer. The next
яка
question
допомога
is,
при
what kind of
вибірковому харчуванні
assistance
у дитини
in
з
the
аутизмом?
selective
Тому
feeding
що
in a child with
консультації
autism?
педіатрів
Because the
та
consultation of
нутриціологів,
pediatrician
фахівців з
and
харчування,
nutritiologists and the
які
experts on the
радять, аби
feeding
їжа
that
просто
are
була
saying that
поруч з
for food
дитиною,
to be
вони
just
не
near the
допомагають і
child,
не
it's not
працюють.
helping in selective feeding. If you just present child with food, it's not helping. The child doesn't eat. So if anything can be concerned is the feeding or nutrition to a child with autism, what would be the best recommendation?
Okay, so eating problems are a significant issue in autism. There is no question. And the problem is that kids with autism, because of their sensory difficulties, will avoid certain foods. And the foods they tend to avoid are the foods that are healthy for them. The foods they like are sweet for the most part, or they have a certain texture. Not unlike my grandson, for example, who was with us last night for dinner. All he wanted to eat for dinner were cookies that my wife had made. So it's, problems with eating are not uncommon in young children. My grandson is 5 years of age. He doesn't have autism, but, eating behaviors are pretty common, both in autism and in typical children. Okay. So it is important to not give in to only providing them food that's sweet or food that they want to eat. Parents will often give in order to reduce distress around the dinner table, in order to make mealtime less stressful. But it's important to start early and not only provide sweet food or food with a certain texture that they'll eat. So giving them healthy food, a well-rounded diet, giving them the options, is important. Now, The parents may have to change the texture of that food. That's okay. You may have to mush it up. You may have to keep the peas separate from the mashed potatoes. That's okay too. You may have to use rewards, like you can watch TV if you eat some more. That's okay as well. Bribery is okay. You can use bribery for autistic children. I can't use it with my grandson because he'll take advantage of me. But for autistic children, you can bribe them because they won't take advantage of you. They don't have a theory of mind where they can predict, if I don't do this, grandpa will do that, and I can get my way. That's too complex for very young children with autism. So giving them rewards for good behavior is totally appropriate and works well. Um, so so I think my main message is that don't give in, provide healthy food, not a lot of juice, not a lot of sweets, not a lot of ice cream, keep it as diverse as possible. Over time, you will see that these feeding problems go away. In our study, nobody had to be admitted to hospital because they were losing so much weight or they needed NG tube feeding or anything like that. In my experience, I haven't seen it get to that point of severity. And over time, these feeding problems go away and you can continue with a reasonably balanced diet. Did I answer that question? Yes?
Так,
Okay,
Yes, thank you so much.
good.
дякуємо. Наступне запитання
The
від
next
пані Віри.
question
Чи
from
грудне
Vira,
годування та
which is
постійна
faced in
присутність
Ukrainian.
матері з дитиною
Breastfeeding and a
в
constant
раннього
presence of
віку, чи
mother
можна
with the child
вважати
from
це
early age.
як
Can you consider this
профілактикою
as the prevention
розвитку
of
аутизму,
development of
якщо дитина
autism?
до цього
If the
схильна?
child has like indicators that the autism might happen, like if the child before had autism and the next child, if you're constantly breastfeeding and you're constantly in the presence of a mother, is that preventing autism at any chance or not?
Oh boy, that's a complicated question. So the easy answer is no. Breastfeeding is not a preventative intervention for autism. Um, um, uh, at least, and there's no evidence to suggest that. Now, if there is, and there are no preventative interventions for autism that are out there. Having said that, it is true that the siblings of kids with autism are at increased risk of developing autism themselves. Okay? So say there's an older child and mom becomes pregnant. And so an older child with autism, mom becomes pregnant, and that baby has about a 15% chance of developing autism because autism is basically a genetic disorder. It will unfold as those genes affect the development of the brain. Having said that, there is work going on about whether, as soon as autism symptoms start to emerge, whether we can provide social interventions that might be beneficial in autism. So, for example, there are programs where the younger siblings of kids with autism come into a group setting with other children and work on their social skills. And there is some evidence that working on their social skills working on their communication skills, working on their play skills has a beneficial impact. So I want to conclude, it's not breastfeeding that's going to make a difference, but I think social interventions, interventions with other children, communication interventions, speech and language therapy. The sooner those interventions begin, the greater the chance they have of benefiting autism. I'm not going to say we can do anything to prevent autism, but I am hopeful that new research that's being done can show that in those who are at risk, social communication therapies can reduce the severity of later autism. But this is an emerging area of research at the moment. That was a long-winded
Так.
answer.
І насправді ви частково відповіли на
And you
наступне
partially answered
запитання.
next question,
Я
actually.
все одно його озвучу, можливо, ми
I'll
його
still voice it out, so
доповнимо.
maybe you can add a
Від
few
чого
things if you want
залежить
to.
соціальне
What
становище
does the
людини з
social
аутизмом в
status
майбутньому,
of the person in the
оточення,
future of is the
лікування
child of the
тощо?
autism? Like,
І
is
чи
it surrounding? Is
використовуєте
it
ви
social part? Is it
немедикаментозне
treatment? And
лікування,
are you using
наприклад, перебування
non-medication
на
treatment,
природі,
like being
спілкування
in
дітей з
nature,
тваринами,
talking with
лікування
animals, and
музикою?
like
І
treatment with music
чи
therapy?
можна
And is
стверджувати, що
can
в
you
сільській
state
місцевості
that in the
нижчий рівень
villages they
аутизму?
have
Це
lower
складне
levels of
запитання.
autism?
Якщо
So such a
потрібно
long
його
vidded
шматочками будемо
questions. If
розбирати,
possible, we
повторимо.
can get it bit by bit, and we'll repeat if you ever miss something out. Thank you so much.
Um, so I just trying to formulate my answer. I mean, early intervention, let's put it this way. Early intervention is important. The earlier, the better. There are basically two schools of thought when it comes to early intervention. One school is applied behavior analysis, LOVAS. So this is very rigid behavior therapy training, 20 hours a week, one therapist, one child, rewarding communication behaviors, rewarding social skill behaviors, rewarding, typical play. There's another school of thought which says more naturalistic behavioral interventions are also effective. So this is young children going to preschool, going to kindergarten. But when they go into those settings, they're given supports to support their social skills with typical peers, to support their communication, etc. So this what we call this naturalistic developmental interventions seem to be as effective as the more strict behavior therapy interventions. But these behavioral naturalistic interventions are still informed by a knowledge of autism and strategies that are specifically directed to facilitate improvements in social skills and communication. Now, there's other forms of therapy that are out there, like art therapy, like music therapy, like you know, uh, being with animals. Those are not autism specific. They're not going to reduce autistic behaviors, but they're going to improve quality of life because it makes kids happy to be in nature. It makes kids happy to be around animals. And I say anything that makes your kid happy, do it. And the more time that kid is happy, the more opportunity you have to communicate with him while he is happy. And that will have a beneficial impact. The happier your kid, the easier it is to treat them to improve their social skills. But those other therapies like music therapy or art therapy, in the absence of trying to facilitate social communication and play, is not going to be effective. Does that make sense? These are complicated questions you're asking me.
Добре, будемо дозувати
I mean,
запитання
we'll
і
be dosing
пропоную
questions differently. Let us talk
дорослих,
about
тому що ми
the
маємо
adults because
низку
we
таких
have a
запитань. Я не
few
буду
of the
озвучувати
questions. I'm
зараз
not
всі
gonna
перелік
voice the
запитань,
whole
дуже
list of
багато.
questions because there are so many of them. I'll try to
Скажіть,
group
будь
them out.
ласка, чи
So please
знаєте
tell
ви,
me,
є ли
do you
терапевтичні
know
методи
any
при
acting therapeutical
нав'язливих
methods
суїцидальних
and
думках
if
у
there's any
дорослих людей,
obsessive
які
compulsive
мають
suicidal
аутизм?
thoughts in adults who have autism?
Well, um, so so let's talk about obsessive compulsive behaviors. So OCD is another. It's less common than the ones I talked about. Um, it occurs at about 9% of autistic people. It can be common in both children and in adults. You need to make sure, here's where the double counting is really important, because often people will misdiagnose rituals that autistic people demonstrate as a sign of OCD, obsessive compulsive disorder. So, so it's very important to distinguish the compulsive behaviors that are part of autism from the compulsive behaviors that are part of OCD. And there's two ways. The most important way to distinguish is the onset. In other words, the more recent the age of onset, the more likely it is to be OCD. OCD, and there has to be obsessive thoughts that motivate the compulsive behavior. Whereas in autism, the compulsive behavior is not motivated by so much by a thought. Compulsive behavior in autism is pleasurable. Compulsive behavior in autism, let me say that again. Compulsive behavior in autism is pleasurable. Compulsive behavior in OCD is distressing. So an assessment of how does the kid feel when they engage in the compulsive behavior is crucial to distinguishing them. If they like it, it's autism. If it's distressing, it's OCD. If it has recently appeared, it's OCD. If it's been there forever, it's autism. So those are the ways to tell it apart. Are there evidence-based treatments for OCD and autism? No. There have been trials of SSRIs for people with OCD using the medications we treat with OCD, and they haven't demonstrated effectiveness. So there are psychosocial treatments for OCD, CBT, response prevention treatment, and that shows benefit. So if a person had OCD, with autism had OCD, I'd start with the psychosocial intervention, the CBT. If that didn't work, then I would try the medication, even though I know there's no evidence, but there's no evidence in the population doesn't mean this individual may not benefit. So you can try it, but be skeptical about whether the medication's going to work. Certainly don't keep them on it forever if they are not responding to the medication. Was there another part to the question? One part of the question was about OCD. Oh, the self-harm? There was a question about self-harm?
Так,
Yeah. So,
так.
for self-harm, I think you treat self-harm in an autistic person the way you would in a typical person. Okay, wait a sec. Maybe the first distinguish to make, there are people with autism who will harm themselves as a form of self-stimulation. In other words, you know, autistic people uh, have a lot of self-stimulatory behaviors, and sometimes those involve harming themselves, like scratching themselves or cutting themselves or, gouging their eyes. We don't see as much of that now as we used to, when I started 20, 30 years ago. So, and generally that only occurs in autistic people with intellectual disability who have profound needs, banging their heads against the wall. That's a different thing than being suicidal, because one's sensory and the other is an intent to harm oneself. Um, so, behavior therapy for the sensory stimulation, that's the root of self-harm, or if it's self-harm with suicidal intent, then that becomes treating the stressors that are influencing the individual.
Дякуємо за розлогу відповідь. Наступне
Thank you so
запитання.
much
На
for such a
ваш
profound answer. The
погляд,
next question, in your
корисними
opinion,
чи є доцільним використання
is there a point in
VR-окулярів
using
для
VR
лікування
glasses
соціальної
for the treatment of the
тривожності
social
у
anxiety in
підлітків
children
з
and
ознаками
adolescents with,
аутистичного
say,
спектру?
autistic spectrum disorders?
What kind of glasses?
VR glasses, virtual
VR,
reality.
Oh,
VR-окуляри.
virtual reality. Oh, well, that's
Так,
interesting.
віртуальної реальності.
So I'm not aware of research yet on virtual reality in autism. It's worth studying. Yeah, it's an interesting hypothesis. Somebody should research it, but I would not, until we have evidence that it's effective, um, I wouldn't prescribe it as a first line treatment over CBT. I'll look into it after and see if there is research that I'm not aware of, but I don't recollect reading anything about that that's available. Maybe at a conference somebody's presented something on it. So I think it's an emerging area. It's worth pursuing for sure. But for routine clinical practice, I don't think we would know how to use it.
Дякуємо. Якщо запитання
So the
від
next
пані
question
Валентини,
is from Valentina.
якщо у дитини з
If a
аутизмом
child
відсутнє
with
мовлення
autism
і
has
методи
no speech, what
комунікації,
kind of
наприклад,
communication methods
використовують у
could be
вас?
used in Canada, for example?
Yeah. So, so this is not an uncommon um, problem. There's a significant proportion of autistic children who don't have speech, and we have to use what are called augmentative forms of communication. And so that's things like a picture board or a picture pics. So, there are nonverbal ways of communicating that can be, some people with autism are able to use quite fluently and communicate quite well. It takes a speech and language therapist with some skill and knowledge to find out what's the best way to communicate nonverbally. Is it a typewriter? Some kids do really well on a computer. Some kids do really well on a typewriter. Some kids do really well with pictures. Some kids do well with, pointing only. So we put too much emphasis on language communication in autism and not enough on the potential for nonverbal forms of communication to be equally effective. So I've seen people with autism who don't communicate verbally, but communicate perfectly well non-verbally and have a rich, fulfilling life. And it just takes a skilled speech and language therapist to know, okay, what's the augmentative form of communication? And there are many different avenues out there. What's the augmentative form of communication that seems to work best with this individual?
Дякуємо.
Thank you so
Запитання
much.
від пані
The
Ірини.
question
Якщо
from
дитині
Irina,
6
if possible,
років
if the
відсутнє
child at age
мовлення,
6
чи
has
бувають
no
випадки, коли
speech,
воно
are there
з'являється в
cases
більш
if it
пізньому
can still
віці
appear
і
in later
дитина
age
не
after
реагує
6?
на
The child
звернення?
does not respond to being like ask something or to its name or anything like that. So the child doesn't respond to speech at all.
Yeah. So the sort of the clinical rule of thumb, is that if they don't have speech by 6, they're unlikely to get it. Now, it's a rule of thumb. So there are exceptions. There are always exceptions. Um, uh, but generally speaking, it's not a bad rule of thumb. But there are some kids who will um, develop speech after the age of 6. There are also kids who, as I just emphasized, aren't speaking at 6, but after six will develop nonverbal means of communication, like gestures, like signs, like pointing at pictures, like being able to communicate with their eyes, like typing on a computer, using a voice box. I mean, never get the point is never give up. Never give up trying to find, regardless of the age, never give up trying to find a means of communicating both verbally and non-verbally that fits with this child's ability. This is the emphasis I made about how we have to modify the environment and never give up, trying to modify the environment to reduce the barriers, to, find different ways to be creative and thoughtful about how we can find ways to communicate, because there's always a possibility. So, yes, that's a rule of thumb, but it's not a fact of nature. And there are exceptions, which means never give up trying to find a way to facilitate communication for that individual.
Дякуємо.
Thank you so much.
Наступне
The
запитання від
next
пана
question
Євгенія.
from Yevhen.
Доктор Сатмарі, спираючись
Dr.
на
Satmari,
всі дослідження, на ваш погляд,
based on
що
all the
провокує
research, in your
виникнення
opinion,
аутизму в
what
дітей? І
provokes
чому
autism in
така
children?
тенденція,
And
чому
why
вони
there's
так
such a trend
прогресують?
that it's
Можливо, ми
progressing so
теж
much?
додамо ще
And maybe we can
картинки
add
в нашу
like a
дискусію.
bit of the twist into our
Чи
discussion.
має до цього
Does
якесь
any
відношення
is there any relationship
дискусія про
with
те,
the
про вплив
discussion that the
вакцинації як
influence of
тригера
vaccines
до
and they
виникнення
as a
розладу?
trigger to autism?
Okay. So, uh, um, again, another opportunity to put aside some myths. So we know pretty well what causes autism. we know it's largely genetic. In other words, if you have two twins that are identical genetically, and one twin has autism, the probability that the identical twin will also have autism is about 90%. So genetic factors play a big role in what causes autism. And we know that from the twin studies. More than that, we've identified over 500 genes, genetic variants that are associated with autism. So not only do we know it runs in families and is genetic, we know which genes, many genes, that are caused in autism. They tend to be either rare genes that have structural abnormalities on them and they affect the brain. We also know that there are more common genes with sort of normal variation in those genes when they add together that they also cause autism. So genetic factors are a big deal. Yeah, there are some environmental factors that cause autism. Advanced parental age, older mothers, older fathers, that's associated with autism. Why? Because older mothers and older fathers in particular are more likely to have these big, uh, uh, what we call copy number variants, so structural changes in brain-related genes. So parental age is a risk factor for some of those genetic variants that cause autism. There are other environmental factors that cause autism. Prematurity. Pretty good evidence that prematurity causes autism. Pretty good evidence that if the mother takes certain anticonvulsants, like valproic acid, that causes autism. Pretty good evidence that measles causes autism. In other words, if you catch measles, that can cause so much brain damage that can look like autism. There's emerging interest about other environmental factors like pollution, air pollution, that might cause autism. Evidence for that is weaker. The environmental factors seem to be more related to the pregnancy and to the age of the parents. We know some things that don't cause autism. And one of the things we know that doesn't cause autism is vaccines. So let's put vaccines aside. They don't cause autism. Let's move on to other causes of autism that we haven't yet determined and figure out what we can do to eliminate and remove those causes.
Дякуємо. Докторе
Thank you so
Сетмарі, у
much.
нас
Dr.
залишається
Satmari,
час
we have
приблизно на 2-3
time for
питання,
one or two
але я
questions,
змушую
depending on how
невеличку
fast, but I will
паузу з
take a
огляду на
small
те,
pause,
що так чи
taking
інакше
into
наша
account that
сьогоднішня розмова
anyhow,
вона
our
включає
talk today includes
розвінчування
also
міфів
the
про
myth
аутизм,
busting
і ми
on
дуже
autism.
рекомендуємо
And so
нашим
we are
учасникам
recommending to our
на платформі
participants
Тияк
on our
є
platform, on
великий
How Are You
огляд
platform, there is a
матеріалу
big,
по
a lot
аутизму,
of
і
materials
там,
about
зокрема,
autism.
є
And it
розвінчування
also,
міфів.
there's also myth
Тому
busting.
користуйтеся, будь
And so
ласка,
by
і так
using this
само на
wonderful
платформі ви
opportunity and also
знайдете.
using on the
Ми вже
platform
мали
that
розмову
we
в
already had a
нашому
talk
проєкті
in our project and
серії вебінарів. Ми вже мали
in a
розмову про
series of
аутизм,
webinars, we also had
тому
the
відкривайте
series on
How Are You
autism. Therefore,
платформ.
open
Якщо потрібно нашу
howareyou.com
технічну команду
and I'll ask our technical
надіслали
team
посилання в чат,
to send
користуйтеся,
the
будь
link to the
ласка.
chat. Please use it. There's a lot
Докторе
of resources.
Сетмарі,
Dr.
запитання,
Satmari, there is
які
a question.
ліки
So,
використовують
what
при
kind of medication it's
самоушкодженнях,
better to use
якщо
in
не допомагає
self-harm in
психотерапія?
case psychotherapy doesn't help?
Um, uh, so, um, so when we say self-harm, do we mean suicidal self-harm that's associated with depression and anxiety, or do we mean self-harm associated with sensory stimulation? If we mean self-harm associated with sensory stimulation and repetitive behaviors, in other words, if the self-harm is an example of a repetitive behavior in autism, then a second generation antipsychotic like risperidone has demonstrated effectiveness in randomized clinical trials. If we mean suicidal self-harm, then and psychotherapy has not worked, then I think it is appropriate to use an SSRI like fluoxetine or escitalopram to treat the depression in self-harm. The fluoxetine or the escitalopram or the sertraline will treat the depression and or the anxiety. But to treat the self-harm, you really need to treat the stresses that led to the self-harm in the first place, whether it's the bullying, the cyberbullying, the rejection, the stress at school, whatever it was that precipitated the self-harm, suicidal self-harm, that needs to be dealt with. But if there's anxiety and depression, it is appropriate to use fluoxetine, escitalopram, or sertraline to treat depression, because those are the medications that we use to treat depression and anxiety in neurotypical children.
Дякуємо. І останнє запитання на сьогодні
Thank you. And the
від
last question
пані
for
Євгенії.
today from
Її доказова
Yevgenia.
база щодо
Is there any
досліджень
evidence
впливу
on
на
the
аутизм
positive
у
influence on
використанні
autism of the
методики
usage of
Томатіс?
methods Tomatis? I guess this is the brand name methodology.
Yeah, Tomatis. So this is auditory integration therapy. I think that's what the Tomatis method is
Так,
on audio integration therapy.
так.
Yes, and the answer is no. There is no evidence. I think there's even been a clinical trial to test it, and there hasn't been any benefits demonstrated with that form of therapy. It's virtually disappeared here in Canada and North America. It's not available anymore.
Дякуємо. І, докторе
Thank you so
Сетмарі,
much,
ми
Dr.
дозволимо
Satmari.
собі
We will allow
закінчити
ourselves
нашу
to
сьогоднішню
finish our
зустріч
today's talk with
приємними словами,
a
тому що
nice
паралельно з тим,
group
як
of
я
words, because
зачитую
in
вам
parallel of
запитання
me
від
reading
наших
out the questions
учасників,
to
я
you,
ще
there's also from our
відслідковую
participants, I'm also seeing
коментарі,
the
слова
comments and
вдячності,
the
які
words of
лунають
gratitude
впродовж
that
всієї
are going
вашої
throughout the
лекції,
all of your
сесії
talk, of your
запитань-відповідей.
questions and
І,
answers.
зокрема, одна
And
учасниця
also
пише,
to
що
one of the
вона
participants are
приємно
saying that
вражена
she's
і безмежно
nicely
вдячна за таку
satisfied
цікаву
and so
зустріч.
grateful for such a
І
wonderful
простими
meeting.
словами,
And with the simple words
зрозуміло,
and so
спасибі
clear
вам
and so
величезне. Ми до
easy
цих
to
слів
understand. Thank you so
вдячності так
much. We are
само
also adding to those words of
приєднуємося.
gratitude. Thank you so
І
much.
додам ще,
And
що
also, I'd just like to
сьогодні у
add
нас
that
було
today
понад 1000
there has been
учасників
almost over
на
a
різних
thousand
платформах, на
participants
платформі
on
Zoom,
different
у
platform, on Zoom
Фейсбуці та на
platform,
YouTube-каналі
Facebook
Кияк.
platform, YouTube
І
channel. How are
важливе
you?
таке
And an
оголошення для
important
наших
announcement for
учасників.
our
Ми
participants.
звертаємо вашу увагу, що
We would like
відповідно
to point your
до
attention that in
введення
according to
з
the new
Фейсбуку,
regulations on
запис
Facebook,
сьогоднішньої
the
розмови
recording
буде
of today's
доступний
talk
без
will be available
пізніше
on the
впродовж
webpage
одного
only
місяця.
throughout 1 month.
Тому, будь ласка,
Therefore,
користуйтеся
please use the
платформою
recording
Кияк або
wisely and use How Are You
YouTube-каналом
platform
Кияк,
or
щоб
your
ви
YouTube
в
channel, How Are You,
будь-який
so
міг
that
мати
without any
доступ
time
до
limits you have access to
ексклюзивної
an
і неймовірно
exclusive
цінної
and amazing
інформації. Ще раз
information. Thank you
дякуємо
so
вам,
much. Yet again,
докторе
thank you so
Сатмарі.
much, dear Dr.
Ми
Satmari.
обов'язково поділимося
We
вашими
will share
презентаційними
your
матеріалами
presentation
з нашими
materials with everything
учасниками
else with
після
our
вебінару.
participants as well after the
І
webinar.
спасибі вам, що
And
цей
also,
вечір
thank you so
були
much for
разом
spending this
з
evening in Ukraine
Україною,
with
з
us, with
українськими
Ukraine,
фахівцями
with
і всіма
Ukrainian
нашими
experts, and with Ukrainian
слухачами.
colleagues, and with all of our listeners. Thank you so much.
Тихого вечора в
Have a
Україні.
peaceful evening
Бережіть
in
себе
Ukraine,
і
who's
до
ever in
нових
Ukraine.
зустрічей.
Stay safe and see you next time. Thank you so much. If you want to say any final remarks, please do.
Thanks, everybody. It was lovely to be with you, and please stay safe, and Slava Ukraine.
Героям слава.